Στο γιο του ο κύριος Klein, Professor Klein. It's a pleasure for us to have you here and give a talk. Το θέμα του κυρίου Klein είναι πρόληψη λοιμόξεων σε πρωτοπαθείς και δευτεροπαθείς ανοσονεπάρκειες. Τεράστιο θέμα που όλους μας απασχολεί και στα νοσοκομεία και εκτός νοσοκομείων. Φυσικά μέσα στο χρόνο που έχει θα καλύψει μόνο κάποια μικρά παραδείγματα, κάποια λίγα παραδείγματα από αυτές τις πρωτοπαθείς και δευτεροπαθείς ανοσονεπάρκειες. So, Nigel, we are waiting for your talk.
Okay. I was just...
Ο κύριος Klein είναι είναι καθηγητής, λοιμοξιολόγος και ανοσιολόγος στο γνωστό, νομίζω σε όλους μας, το μεγαλύτερο νοσοκομείο παιδών στην Αγγλία, το Great Ormond Street στο Λονδίνο. Είναι καθηγητής επίσης στο University College του Λονδίνου. Ασχολείται πάρα πολύ με ανοσοκατασταλμένους αρρώστους και όποιος έχει περάσει από το Great Ormond Street είναι κυρίως ο σύμβουλος των λοιμόξεων σε μονάδες μεταμοσχεύσεων, σε μονάδες στα ανοσοκατασταλμένα παιδιά, ογκολογικά τμήματα. Έχει ιδιαίτερο ενδιαφέρον στη μηνυγκίτιδα, στη σύψη, στη λοίμοξη HIV και στις λοιμόξεις ανοσοκατασταλμένους. Μάλιστα, μόλις τώρα, πριν από λίγες μέρες, γύρισε από την Αφρική, όπου ήταν εκεί με προγράμματα HIV λοίμοξης σε χώρες της Αφρικής, στην Νότια Αφρική και κάποια άλλη χώρα, και σε Ουγκάντα νομίζω. Είναι πολύ γνώστης του θέματος. So, Nigel.
Thank you very much, Emmanuel. I'd really like to start by thanking Emmanuel and the organising committee for inviting me to this wonderful place. From the second I arrived, I felt very at home, and you really have a fantastic way of welcoming guests. So I thank you very much for that. And I really want to give thanks as well to Constantino, who's had the task of trying to get us over here, and she's done an amazing job, as she has done today. There are some times in when you're asked to give a talk that you reflect on your own lifetime. And I realise that this story of preventing infections in immunocompromised patients has happened in my lifetime. And I really want to start early in my lifetime, because I think there was work that went on at that time that's really influenced the way we think about infection in immunocompromised patients. So I'm going to go to 1966. Now this is Bobby Moore holding the World Cup. It's the last time England ever did anything special in the football world. So it's the only time that people remember that we actually had anything to celebrate, in contrast to Greece, that of course have had much more recent successes. So that was one of the things that happened in 1966. The next thing was that somewhere around that time was probably the first time that I was giving a talk. I had some hair then. The microphone was not as sophisticated as the ones I've got here. And I suspect I may have talked more sense than I will today, so you'll just have to judge that. But by far the most important contribution to this field in 1966 was the seminal work by Bodhi, who recognised for the first time the relationship between outcome, infection, and leukocyte count in patients who are being treated for malignancy. So what Bodhi did was look at a study over of 52 patients who had leukemia, and they were treated with what would now be considered quite a minimal chemotherapeutic regime. And at the end of that study, there were only 5 patients alive. And I think the tragedy of the work that he presented was that it wasn't recognized at that time that these patients were going to die from an infection. And I think that contribution is amazing, considering, as I said, it was within my lifetime, and now it's just taken for granted that we treat infection in the way that we do. Perhaps the most important finding was the relationship between neutrophil count and mortality. And as we say in England, if you didn't manage to increase your white cell count in the first week of life, then it was curtains. In other words, you died. So it was a very, very telling contribution to our field. Following on from that study, people recognized that you either had to give very early treatment when you suspected an infection, or that you had to give preemptive treatment when you thought someone was likely to get an infection. But the big question at that time, and in fact for many years afterwards, was, is that enough? Is there anything else we can do? And actually, there's very little in the literature, apart from sporadic case reports and small series, where people really started thinking about prophylaxis as a way of preventing infection. So when I first started, and in fact in relatively recent times, my experience of children with malignancies and with primary immunodeficiencies were patients such as these shown in this slide, who had devastating infections, and if they just survived, they had severe handicap at the end of it. So that was very much the way things were, even though we had effective antibiotics at the time, and we started giving patients treatment very early. We still suffered from many cases such as this. I'm going to move forward a bit to 1981, which was when the HIV epidemic was first recognized. And it was recognized because of 5 cases of adults with pneumocystis pneumonia. And this heralded the onset of the recognition of HIV, and was extremely important because the association between pneumocystis and immunodeficiency had been recognized earlier, as I'll show you in a minute. But really, it's interesting that it was so important in the HIV infection. So you all know, many of you here will have seen pneumocystis infection. We fortunately don't see it very often any longer, but it was a devastating disease, and the mortality was extremely high for patients who actually contracted the infection. Back in the 1970s and 1980s were studies really by Walter Hughes, who did some seminal work again in showing that pneumocystis was a major complication of primary immunodeficiency, both in patients, in children, and in adults, and was a major cause of mortality. Interestingly, it took some time before people recognized that there may be a way of preventing this infection by giving prophylactic antibiotics. So Walter Hughes again did the seminal work on looking at Septrin prophylaxis that prevented pneumocystis infection. Firstly, the study looked at daily Septrin, and then following that was the study that showed that you didn't have to give Septrin every day and could still get substantial benefit in terms of prevention of contracting pneumocystis. But as many historians who write about the HIV period have noted, it wasn't until 1989 that there was a directive, a recommendation from the CDC, that patients with HIV should also start taking septin prophylaxis. So the prophylaxis field has moved quite slowly, and it took some time for people to institute these findings into clinical practice. So many groups around many countries had not instituted septin prophylaxis in their patients to prevent pneumocystis. When they did, the pneumocystis rates plummeted. So an extremely important intervention, and the first real evidence that prophylaxis could be extremely beneficial in patients with an immunodeficiency. So on the basis of that, various recommendations were made, and the WHO in 2006 issued the following recommendations, which essentially say that you treat everyone from 4 weeks of age onwards who you either suspect of having HIV or has been proven to have HIV, and that you carry on using septin when you suspect that the immunodeficiency is severe enough to predispose you to getting pneumocystis infection. Similarly, most units looking after patients with malignancies or other immunodeficiencies instituted septin prophylaxis to prevent pneumocystis infection. So septin became the mainstay and remains the mainstay of treatment for prevention of pneumocystis and, as you'll see, other infections. But the question really is it just working because it's acting against pneumocystis, or is it working through other mechanisms? And I think this work from Di Gibb some years ago now, before we had antiretroviral therapy, demonstrated how effective cotrimoxazole is at preventing infection. So they did a study where they gave children with HIV cotrimoxazole and had a look at its effect on mortality. And as you can see in this, here, that the group that had the cotrimoxazole did much better than the placebo. So as I said, this was pre-antiretroviral therapy, but it demonstrates the use of septin prophylaxis. Probably not, they couldn't work out why it was working because they didn't have good enough microbiological data, but they suspected it wasn't just working through its effect on pneumocystis. More recently, there's been another trial looking at cotrimoxazole in the era of antiretroviral therapy. This was a very large study done in Africa of over 1,200 children. They were all children who were antiretroviral therapy naive, and they started therapy, and a group of patients, they all started with septin prophylaxis, but a group of children after 2 years of age then stopped their septin to see what the outcome might be. And actually, to most people's surprise, there was still a substantial effect of stopping septin. So whatever one looked at, whether you looked at hemoglobin, weight for age, in fact even CD4 count, you did better if you had septin prophylaxis. So those WHO guidelines from 2006 looked outdated because they said once your immunity is good enough, you won't need septin prophylaxis. And actually the latest WHO guidelines are going to suggest that you carry on taking septin for some time after reconstituting a good CD4 count, and it's still unclear for quite how long it should be recommended. We've been doing work on why it might be so effective. Clearly it's an antimicrobial, and its efficacy is partly due to that, but there are some other things that it seems to do. It may have an impact on your inflammatory status. So this is work where we stopped in the group that stopped the septin, shown here in the orange. They ended up with higher inflammatory markers, this is CRP and interleukin-6, than the group that continued their septin. We can speculate it may have something to do with preventing microbial translocation, but it may have other mechanisms that as yet we haven't understood. But it indicates that cetrin prophylaxis has lots of strengths, and definitely in the field of HIV, it's going to be advocated for longer than we've hitherto used it for. So we come to this question of what about, that's in HIV, but what about cetrin prophylaxis in other immunodeficiencies? We know about its effect on PCP, but there was less data around to say how effective it was in other spheres. So as I said, lots of studies, many of them, the ones in children were often extremely small, so much of this data comes from adult work. But a relatively recent Cochrane review has put together all of the trials that they consider fit to use within this analysis, with some over 13,500 patients. And the bottom line is that cetrin, that antibiotic prophylaxis, is very effective at reducing mortality and reducing infection. And you can see from the conclusions that whilst it was extremely effective at reducing the complications and number of infections, which prophylaxis you used didn't seem to matter that much, although there was a suggestion that if you used quinolones, that you had a faster resolution, and there was a suggestion as well that if you had gram-negative infections, that you did better. And you can see here, this is the, any of you who want to look at this is an important paper. And you can see here that it's a bit difficult to see because of the, but these are the quinolones up here, and this is cetrin here. And you can see that nearly all of them show a benefit of taking antibiotic prophylaxis in patients with immunodeficiency, predominantly due to malignancy. This area of ciprofloxacin usage, quinolone usage, is still an ongoing debate. You heard from Tom Walsh today about our fears of gram-negative resistance, and yet more and more patients are going on to quinolones because of the data from the various studies that have been done. This is just one of those studies, and this study again showed great benefit of taking the quinolones as prophylaxis at preventing infections. So it's quite difficult to argue against such data, even though we also know that antibiotic resistance is a potential problem. And again, if you have a look at all of the various parameters that they looked at, again, it's rather small to see, but the quinolones were extremely effective at reducing infections and the various indices of those infections. The only thing was that, so you had two things. You had the cetrin that looked like it was equally as effective as the quinolones, but more recent studies of the quinolones say they may be a little bit better than cetrin. And on top of that, some individuals who look after patients who have bone marrow transplants were unhappy about cetrin because cetrin is known to be a myelosuppressive. So two competing concerns, they continue to be competing concerns about the gram-negative resistance, but also about the bone marrow toxicity of using cetrin. And I think these sort of studies have started to come through and continue to come through, really suggesting that if you've got two drugs that look similar, then you should go for the one, in the context of bone marrow transplants, you should go for the one that causes less marrow toxicity. And so there's been pressure, really, for bone marrow transplant units to take up the use of quinolones, and it is a progressive trend. Whether it's right or not we'll know more in the future. This is some work showing what cetrin may do to your progenitor cells. This is what should happen in terms of colony-forming units if you take progenitor cells and you grow them in methyl cellulose. And this is what happens if you've got cetrin. So there are concerns about what might happen to your bone marrow, and in the context of trying to get a new bone marrow, clearly Septrin has its potential problems. So I think what we do is we give cotrimoxazole to all patients who are rendered leukopenic. I think its efficacy for protecting against pneumocystis is there, and its efficacy against other infections is also clear. We do stop Septrin when we first start our process adding when we first infuse the bone marrow, because of its potential effect on the bone marrow. But we started again once engraftment has taken place. And the other thing you can do is you can use different regimes of your Septrin. Because we now know from that work from Walter Hughes that actually giving Septrin 2 or 3 times a week is sufficient to prevent pneumocystis, it does mean that you can use it to prevent pneumocystis by only giving it for a couple of days a week. And that gives you a lower total dose of Septrin, and it means you can get your protection from pneumocystis with less marrow toxicity. So different regimes you can use, and you can see here, I've shown up here, the various ways we can do it. You can use folinic acid as well, although that can reduce the efficacy of the Septrin, but many units do use that. Ciprofloxacin, we have resisted the use of ciprofloxacin in our unit for many years, even though most adult units now use ciprofloxacin routinely as prophylaxis. We finally succumbed because of the problems we're getting with gram-negative infections, and we do use ciprofloxacin prophylaxis in high-risk patients only. We don't routinely use it in all our immunocompromised patients, but we do use it in the high-risk patients undergoing bone marrow, and you'll see different policies around the world. I'm not saying ours is right, and we've only just started using ciprofloxacin like this. You'll see that the most important thing that we do is chase quinolone resistance. So we keep checking the stools for quinolone resistance, and if we find quinolone resistance, we stop the ciprofloxacin. So that's an approach that we've taken. I'm not sure every unit, I know not every unit does that, but that's our attempt to try and come up with a way of being able to use this medication because of its proven efficacy, but without trying to limit the risks of developing severe gram-negative resistance. Now, the interesting thing is I don't see many patients like this any longer. So it has made a difference. There's no doubt in my mind that prophylactic antibiotics have made a huge difference to what happens to our patients. I'm not saying these images are things of the past, but I don't know about your own practices, but I don't see these sort of cases very frequently anymore. So I think antibiotic prophylaxis works, and I think that it's here to stay, but we all fear about what's going to happen in terms of antibiotic resistance in the future. So this is really just in summary about our ciprofloxacin. Really, you've got to keep chasing your resistant organisms and think about stopping the prophylaxis if you find them. So I'm just going to move on very briefly to viral infections. Can we prevent viral infections? Well, as you all know, we don't have very many drugs to use to treat viral infections, so our options are quite limited. We do know that if patients at risk, for example, those that are undergoing a bone marrow transplant, we know that there are particular phases of the transplant that patients are particularly vulnerable to various infections, and particularly viral infections. And the major viral infections that we worry about are recurrences of herpes simplex, CMV infection, and we now see a lot of adenovirus infection in our patients. The herpes simplex story is quite straightforward. We know you can use acyclovir prophylaxis, And without acyclovir, you suffer from recurrent herpes simplex infections and reactivation of varicella. So acyclovir prophylaxis is definitely worthwhile doing. It's relatively non-toxic, and all of our patients who are at risk of getting HSV recurrences or VZV recurrence are on acyclovir. What's much, much harder is what to do about CMV. So we think from various studies, mostly in solid organ transplants, that CMV, you can get some benefit of preventing CMV by using acyclovir or valacyclovir. But once you have active disease, it has no effect on your CMV. So it may be useful as a prophylaxis, and it may have some benefit. But once you get CMV, once you start to get a CMV viremia, there's no evidence that you get any real benefit from acyclovir. So you have to decide what to do about that. And again, the Cochrane reviews are extremely helpful with this. And they've had a look at the difference between giving prophylaxis with either ganciclovir or valganciclovir or another anti-CMV agent versus preemptive treatment. In other words, you start treating only when you either patients at particular risk or that you've got evidence of a CMV viremia before a patient is unwell. Their conclusion is that preemptive therapy is the way to go. It's as effective as giving prophylaxis, and it definitely gives less toxicity, particularly bone marrow toxicity, compared with giving prophylaxis. And that's the route we've gone. We use preemptive therapy. We routinely measure our CMV viral loads. Don't worry too much about the numbers here because it varies a bit depending on the assays you use in your laboratory. But depending on your assays, you work out your levels that you decide you're going to use to monitor. And if patients go above that level, then you start treatment. The treatment options are essentially ganciclovir, valganciclovir, if you can absorb, and foscarnet. And if those don't work, then we go to cidofovir. So we have got agents that work with CMV, and again, I think this approach is definitely helping our patients while they're still reconstituting their bone marrows and prevent them from getting the complications of CMV disease. So my final part of the talk is really about non-antibiotic stuff, non-antimicrobial stuff. And that is that, we're in the world of increasing antibiotic resistance and probably antiviral resistance as we use them more, and definitely antifungal resistance. We're going to have to be more careful about how we do things. And we're not very careful because we work in environments that are intrinsically poorly suited for doing what we're trying to do. So this is an aerial view of the hospital I work at, Great Ormond Street. It's got some old buildings, some new buildings. It's in the centre of London, and so it's extremely crowded. And I assure you that whilst the planning of each bit of the building may be excellent, the planning of how they all fit together is not. And what I always say is, if you put lots of very sick people with immunodeficiencies who have diarrhea and coughs, and particularly children where they've got other children visiting them and parents going in and out with coughs and potentially being able to spread infection, then these are intrinsically dirty places. There are just some places that are dirty. You just have to accept the fact that some places will have lots of organisms around that are potentially transmissible and potentially cause infection. So hospitals are dirty and they're extremely busy. We did a study looking at the activity in our intensive care units, and we just by monitoring, we just had people who were monitoring what the nursing and doctors staff do and what the cleaners do, and what patients' families do. And the bottom line is they have huge numbers of contacts with every surface you could think of. And perhaps if you just follow the activity. We just looked at the activity of people going through an intensive care unit, and each line there, it just represents one movement of an individual in 10 5-minute periods. And you can see just how much traffic goes through hospitals. We have to think of better ways of doing this. Most of this was because people went to get gloves from a cupboard that was the other end of the ward, when actually you could have put the gloves at the beginning, at the entrance of the ward. So a lot of it is just about not thinking about it, but each time someone goes through the ward, the potential for spreading infection is important, is there. Of 43% of the total rounds included at least one hand wash. In other words, each time someone went through the ward, because they went through the ward, they ended up having to wash their hands. And that's quite important because, as I'll show you in a minute, those wash basins may be a very important source of infection. Coming on to hand basins, one of the things we noticed was people often don't know they've got hand basins present because they have curtains around the beds. And actually what you can see here is if you start drawing curtains, you can't see where the hand basin is. And if you look at whether people use a hand basin, their use of the hand basin is determined by whether they can see the hand basin. So this is something we've now altered in our intensive care units and in our bone marrow transplant units so that people can see the sink easily, and they know exactly where they need to go to wash their hands, and hopefully not go across the whole ward to try and find a wash basin. The other thing we started to do is to look at the way a building is constructed and the way we use it to see whether you can see particular hotspots for infection. So you can start taking swabs from various sites and from the air, and you can work out almost like a weather map of where you have concentrations of bacteria. So you can see whether or not this is due to a ventilation problem or the way you're organising your ward. So areas, for example, shown red here, have very high levels of bacteria that we find, and if you persistently find it at the same site, then you should have a look at the way you've constructed or organised your ward, because you may be able to do something to reduce that risk. The other thing that we have, and I'm sure all of you would like to say you don't have, are logistics failures. I just go around with my camera as I'm doing ward rounds and I take pictures like this. This was just in one of the sluices. Someone had put all of these sheets ready to be washed, and they're just shoved into the sluice because that gets it off the corridor. That can't be very good use of your space, and it can't be good for infection control. You can see here that you've got the same type of problem. There's a pram there, so there's a baby there, and you can see that someone's put the sheets right by the sink and by the bin. Again, not brilliant. And the other thing that we find is people don't ever put shelves to put your notes on. So people always put the notes wherever they can. This is on top of a bin. Very often people put it on the edge of a sink. And the other thing people do is they just don't do things properly. So here's a toilet seat that's been put the wrong way round. This is not from Great Ormond Street, but from another London hospital. Just simple things sometimes make a difference. Where you put your gels. Again, we've done a lot of work trying to make sure that you put your gels in a place that people will easily find, rather than for people to have to go and search for them. And the other thing you can do is you can have a look at sinks. And I mentioned to you that sinks, we're finding that sinks themselves, the design of sinks isn't optimal, and sinks are extremely full of bacteria. And if people put their notes on the edge of a sink, they are very likely to pick up bacteria. And we definitely have proven cases now where organisms have come from a sink and found their way into a patient. And this just gives you some idea of the sort of organisms. We see everything, coliforms, gram-positives. They're at all sites within the sink area, and it's something that we need to take account of. The final thing I just want to say is about door handles. We know that if you look at door handles, they get infected. If you have to use a door and push a handle, then you will take those organisms that are on the door handle onto your hand, and you could potentially spread those to a patient. Depends on the different door handles. Some are worse than others, but generally things where you pull or push in a limited area, you're more likely to pick up organisms. And so we've done a lot of work to try to reduce the number of bacteria around our hospital. And this work has shown that actually, compared with the average school, our outpatients now is cleaner than a school. So considering our patients are coming in and they're potentially infected, that's an achievement. But it's definitely worthwhile doing if we want to reduce the risk of spreading infection in a context of very immunocompromised patients. So I know I'm running out of time, so I'm just going to sum up by saying that infections can be prevented in children who are immunodeficient. It's not just a case of antimicrobial. All modalities that you can use, such as boiling water for Cryptosporidium, and organising the way you organise your wards to try to reduce the risk of transmission is also extremely important. As you heard this morning from Tom Walsh, antimicrobial resistance is extremely worrying. We need to keep a close eye on that as we're using antibiotic prophylaxis. But I don't think we can stop using the prophylaxis because of it, because the data is so good that it's being helpful. But you will need to tailor your policies to your own particular unit. That what we do at Great Ormond Street may not be appropriate for here or for another place. You have to know what the major problems you have are, and then you have to tailor your policies to suit those. And just finally, to do all this work, there's lots of people involved. This is just a small number of them. You need to work as communities to try to come up with the right policies. Microbiologists, our bone marrow transplanters, our infectious disease team, our immunologists, our oncologists. We work with our hospital designers, we work with our logistics managers, and we work with our builders. So you need to bring into play all of the people that you can to try to limit the risk of infection, so that you don't blow the opportunity that we currently have of being able to use effective antimicrobial prophylaxis to prevent infections in our extremely valuable immunodeficient patients. Thank you very much.